The recording will be posted on the advisory committee's webpage shortly after the meeting. For everyone's reference, today's agenda can be found under the first tab in the meeting materials. Our stakeholder committee chair, Eileen Cody, is unable to make today's meeting. So we have Bianca Frogner, the cost board member and chair to the advisory committee on data issues, who will be filling in on her behalf. And I will turn it over to Bianca now so she can kick off the roll call and overview of agenda. Where I saw her name. Okay, I think she didn't accept it. Sorry, just one moment. Making sure that Bianca is able to join as a panelist so she can actually speak. Okay.
Hi, folks. Sorry for for having some technical difficulties on my end.
I can hear you, Bianca. Can you hear us? Okay.
I can hear you now. Yes.
Okay, perfect. Okay, yeah, I think you might have missed what I said. So I kicked off the meeting, let everyone know the meeting is being recorded, and I will go ahead and turn it over to you, and that you're going to be filling in today on behalf of Eileen Cody, and that you will help lead us through the agenda and roll call.
Okay, well, thank you so much. And I'm sorry again for my technical difficulties on my end. Yeah, so I'm Bianca Frogner, the chair of the Data Issues Committee. So welcome to advisory committee members. It is now 2:06. And I call the November 20th Advisory Committee of Healthcare Stakeholders to order. So I'll ask you all to open your slides to tab 1, the agenda. So we'll do a brief overview of the agenda, then we'll do roll call, then we'll review and approve the August 21st, 2024 meeting summary. Then we'll open up the floor for any public comments. Following that, we will discuss the stakeholder committee and cost board connection. So what's the relationship there? Then we will hear from our presenters today. Eli Rushbanks, the General Counsel and Director of Policy Advocacy at $4, and Julia Kellison, Consumer Attorney at Northwest Justice Project, who will talk to us about the impacts of medical debt on consumers. Afterward, Gary Cohen with Health Management Associates will lead us in a discussion so we can start wrapping up on the topic of medical debt. And then we'll adjourn today's meeting, but then there is a joint meeting that will begin shortly after. So thank you for being here today. I know it's going to be a long afternoon here, and I look forward to a productive meeting, and I hope you all are doing well post bomb cyclone storm. So as we get going here, I'm going to start to go through member roll call, as I will call each member by their first name in order listed on the agenda. Which is in alphabetical order by last name. Please unmute and say here to let us know that you're here. So let's get this started. Emily.
I'm here. Thank you.
Thank you, Emily. Patrick.
I'm here.
Thank you, Patrick. Bob. Bob. Bob Crittenden. No, not hearing him. Paul F. Paul Fishman. Not hearing anything. Justin. Justin Gill. Not hearing him. I'm sure the board will let me know if anyone has joins us later. Nariman.
Hey there, this is Justin. Sorry,
Oh, hi, Justin.
I wasn't out as a panelist, but now I am. Hi
Great.
everybody. I'm Justin Gill with the Washington State Nurses Association. Happy to join y'all.
Thank you, Justin. Great to have you. Uh, Nariman, just want to check. Did we get that? No. Adrian, I think she emailed that she may not be able to make it, but just want to check. Nothing changed. Adrian Jones. No. Jody. Jody Joyce, are you here? Okay, I'm not hearing anything. Louise.
I'm present, thank you.
Thank you, Louise. Stacy. Stacy Kessel. Not hearing anything. Eric.
I'm here.
Thank you, Eric. Vicky. Vicky. Vicky Lowe. No. Okay, Natalia.
I'm here.
Thank you, Natalia. Sulan.
I'm here, and just for the record, my last name is spelled wrong. I don't know if it matters or not, but just
Oh.
wanted to
Thank you for picking that up. So it should be Mlynarek, right?
thank you.
Okay, thank you. Noted. Michelle. Michelle Ratala. Nope. Paul S. Thank you, Paul. Dorothy.
Here.
Thank you, Dorothy. And Wes.
Good afternoon. This is Wes. I am here. Would it be possible, though, for somebody to send me the meeting materials? I have not received those in advance of the meeting.
I also don't have them. This is Natalia.
So hopefully someone on the board can help out with this. This is also posted on the website. So in case anyone isn't able to get it directly, meeting materials are on the website also. But hopefully we'll get that reconciled. Okay, any other board members that I missed or who may have showed up that did not get a chance to say that they're present? Okay, not hearing anything. So let's go ahead and go open up slide to tab number 2. This is the meeting summary from the August 21st meeting just a couple months ago. So, and we would like to get approval of the meeting summary. Please know there's a recording of the last meeting posted on the HCA web page for reference if that's needed. And so I do see a hand raised. I'm not sure who's behind. I know HLA.
Hi, Bianca. Hi, this is Emily Bryce from Northwest Health Law Advocates. Sorry if it's not coming through clearly. I had a question on this because I noted that these are the minutes from the joint meeting. And when I went back and looked at my calendar, we had a stacked meeting of the stakeholder only committee for the first hour and then the joint meeting for the second hour. And so I only see the second hour reflected in the meeting minutes. Does that make sense?
Yes, that makes
So I don't know if
sense.
that's a concern or not, because it may be that we're taking the notes separately for those 2 items, but I just wanted to note that I believe that there was an initial hour that was focused on a presentation on medical debt. I went back and looked at my notes because I remembered being at the first part of the meeting. So that's something maybe for staff to take back. This didn't look inaccurate to my knowledge for that second half, but there was a first half of that meeting. Does that make sense?
I'm going to ask HCH staff if you have any comments. When I'm looking at it, I can't tell. I mean, it says that's the meeting minutes from, let's see, how does it describe itself? The 2 to 3:30 hour, where there was, it does talk about how Eileen was the chair serving that meeting, doing public comment, an update on the cost board meeting.
Maybe I am looking at a different set of documents because I did get the documents and it looks different to me. I'm looking at the June 12th.
This one that let's see,
That
I
was what was
pulled down.
attached to
Oh, okay.
my documents. Okay, let me,
Let's see.
that's okay, that's in the data only. Okay, sorry. So there are two different documents that we got. One is called data only meeting packet, and that one shows the November, sorry, the August minutes. And then I guess the other one, the joint meeting packet, shows the June minutes. So that's the one that I had the question about, the June minutes. And happy to take this offline.
So let's see. So let's just make sure. So we are going to have a joint meeting after this, starting at 3 o'clock, and there is a separate meeting packet for that. This healthcare stakeholders meeting has its own packet that's entirely separate. And that's the one that I see does seem to have August minutes. Now I'm not so sure what was attached to the meeting invite. I did personally draw this down from the HCA website. So
Okay, that's fine. Why don't we
yeah.
go ahead and
No,
move
thank you.
forward, and that's something that we can address offline. I'm sure it's fine.
Yeah. Well, I am hearing two other board members do not seem to have access to the minutes either. So I do want to make sure, in order to get a meeting approval summary, if others on the call or on the advisory committee, if you do see the August 21st minutes and meeting summary, if you have any comments in the meantime while we solve some of these issues. And I do see Rochelle, I just wanted to check to see if you have any comments.
Yeah, the meeting materials did go out. We sent it as separate emails. So one email to the Data Issues Advisory Committee, and in that email, it should have had two separate packets, one for the joint committee and then one for the data issues only portion of the meeting. And then we sent out a separate email to the stakeholders, same thing, stakeholder advisory committee materials only as one packet, and then a separate packet for the joint. So it sounds like some of the meeting materials got through to some of the committee members, and some didn't. So we are trying to resend that. That way you guys can follow along. Otherwise, definitely refer to the slides that will be displayed so you have the materials in front of you. And we will make sure that we go through and update the list to ensure that the emails that you provided us are updated and accurate. I don't know why it wouldn't have gone through for some of them and not the others, so I do apologize about that. But the meeting materials that we're referring to right here in terms of the minutes should be in the packet for the stakeholder advisory committee only, and this is just for the last time that you guys all met as a group, the advisory committee of stakeholders meeting summary.
Bianca, this is Michelle Needham in the room. I would suggest we hold on voting on those minutes, then take that up in the next meeting, and just allow the committee members to get a complete packet time.
Okay, thank you, Michelle. You're a little hard to hear, but I think I heard you say let's hold off on approving these minutes until the next meeting so that we make sure that everyone has an opportunity to take a look. Okay. Great. Okay, so then I'm going to go ahead and I guess pass this back to Rochelle for public comment. Oh, Rochelle.
Thank you, Bianca. Okay, so we don't currently have any written comments or signups for public comment at this time. So if you have not signed up and you would like to provide public comment virtually, please raise your hand at this time. We will send you an invitation to be promoted to a panelist, and this will allow you to unmute your microphone and to come on camera. And if you can please provide your name and your affiliation, if any, before speaking, that would be great. So we will go ahead and open the floor now to public comment. I do not see any hands raised. I will just give it another moment. Okay, it doesn't look like there's any public comment, so we can move on to tab 4 at this time.
Okay. And you're taking care of this, Rochelle, right?
Yep. Okay, so this section is just to give you guys a brief overview again of the connection for the Healthcare Cost Transparency Board and the advisory committees. I know that there have been questions in terms of the work that the advisory committees are doing and how that ties back to the Healthcare Cost Transparency Board. So this is just a good visual reminder that the cost board is the main governing entity and that the advisory committees help support the work of the cost board. So if you go to the next slide, Audrey. Perfect, thank you. Okay, so the cost board is responsible for reducing Washington State's healthcare cost growth by determining the state's overall healthcare expenditure through an annual data call, setting a healthcare cost growth benchmark for providers and payers, identifying cost trends and cost drivers in healthcare system, bringing transparency to healthcare spending here in the state of Washington, identifying system-wide solutions for affordability, and reporting annually to legislature, including providing recommendations for lowering healthcare costs. So just a reminder, the overall charge of the cost board and how that ties into the advisory committees. So here, the stakeholder committee cost board connection, you can see the current cost board priorities are lower healthcare costs for Washingtonians. Current policies under consideration include high cost items impacting consumers such as medical debt, which can obviously be a consequence, but not the main issue to address. And then looking at medical debt policies. And so some of those policies have to do with high costs, which can lead to medical debt, negatively impacting consumers, their credit reports, and impacting them being able to seek medical care, having that be a barrier to care. And then additionally, is there a question that came in? Oh, okay. Additionally, growing issue year after year, and then it requires focused attention specific to medical debt. And so how that ties into the stakeholders committee goals, as you can see, is the cost board did charge this committee with identifying opportunities regarding medical debt to slow cost growth and address growing affordability concerns. Medical debt policies recommended to the cost board can help address high costs from different angles. And this conversation helps tie back to the cost board and their ability to be able to make informed decisions about potential policy recommendations in the future. So that being said, now I will turn it over to our panelists who are going to provide an overview of medical debt, consumer medical debt. We have Eli Rushbanks and Julia Kellison, who will be doing the next section.
Hello, everybody. Looks like I am up first. Are we just doing like I'll just kind of verbally do next slide method?
Yeah, that's perfect.
Okay, perfect. So hi, everybody. Thanks for having me. Eli Rushbanks, General Counsel and Director of Policy and Advocacy at $4. $4 helps patients get through hospital charity care processes. We help them apply and we do the follow-up. And we do an appeal if necessary. And we generally just kind of work to get the word out about these programs. Next slide, please. So I probably made way too many slides for the time we have, so I'm going to breeze through a few of these. These are not stats that I'm guessing are new to anyone in this meeting, but I put that there's 188 million people on the edge of poverty because the next slide shows that medical debt, when we look at that one single cause, according to census data, is the largest single cause of pushing people into poverty or into financial instability. Next slide, please. And this is just a bunch of the other like really depressing stats around medical debt that a lot of us probably know. The biggest one to me is that 1 in 4 Americans avoid care or stretch medications because of the cost of care. Next slide, please. So we have charity care. I'm assuming everyone in this room is like broadly familiar with charity care, but quick recap is it's a mandate usually by policy, even though a lot of hospitals do it, even if it's not mandated in their state, given their regulatory regime, to give discounts to out-of-pocket costs to low and middle income patients. Washington, we've had this for like 30 years or more now. Even though this is newer in a lot of other places, at least it's being mandatory. So with all of the depressing stats that we saw in medical debt from the last couple of slides, $4 set out to do some research around the role that charity care, or maybe like the failure of charity care, the role that is playing in the medical debt problem. Because in theory, we have data that suggests about 70% of medical debt is from hospitals. So in theory, if hospitals are required to give a discount to patients to get their bill down to something that they can afford based on their income, which is ostensibly what charity care aims to do, we shouldn't have this huge debt problem. Next slide, please. These are just other terms I may slip in and out of for charity care, but we can go on to the next slide. So as a quick primer again, before we get into the finding of our reports, the process for charity care now is that patients have to apply for it. Very little of this is automated, even though that's changing. So there may be some providers on the call that could take issue with me saying that. But this is largely a paper-driven process in most hospitals now. Patients have to get the application, fill it out, submit it oftentimes via fax or paper mail, with sometimes multiple forms of income and multiple forms of asset verification. So just as a quick primer for like what we're all talking about here. Next slide, please. So the first report that we put out earlier this year tried to measure the amount of charity care that we think is missed by providers annually. And we're working with it, and this is annual, this is not just, or this is national, this is not just in Washington, and we're working with imperfect data, but I think we made a pretty good case if you go read the methodology in the report for why that number is at least $14 billion a year that is just ending up mostly in debt pools and on debt collection dockets across the country. We have pretty good data that suggests that over a third of hospital bad debt is held by patients that are 200% federal poverty level or below, which pretty much across the board is the threshold for people who are going to be eligible for 100% financial assistance. Next slide, please. We have data in Oregon from a report that we published a couple of years ago where we looked at the debt collection docket. And we didn't have the resources to open up every single case, but we looked at one hospital's lawsuits in small claims court for one quarter, I believe in 2022. And we found that 4 in 9 patients who were being sued in the cases where we could see their income in the court filing were eligible for 100% charity care under state law. So, given that it's all the Pacific Northwest, the laws are, largely similar in how they're structured, and a lot of the providers work in both states. We're estimating that that would be a pretty consistent finding in Washington as well. Next slide, please. So the next report that we published, we tried to look at, okay, why is there this $14 billion problem? Why is there so much charity care falling through the gaps? So we put together a survey. We hired a company that got us like a census matched population of folks in, I think it was 1,500 respondents or something in that range, to try to, all the respondents were highly likely eligible for charity care based on their income and household size. And they had a bill from a hospital that they couldn't afford in the prior 12 months before the survey. We structured all of our questions to try to analyze whether charity care was known to patients, whether the process was easy for them to get through, and whether these programs were administered in a fair and equitable way. Next slide, please. So the bottom line out of that result is that only 29% of people who are eligible for charity care are receiving it. Next slide, please. So there are a lot of stats in this report for anyone who's interested. I pulled out a few that I think paint a representative picture of each of these buckets. So on the question of like, is charity care known to patients? Straight up, the answer is just no. One stat that's not in here is that 65% of respondents said that they had never heard of charity care. About half of people reported that they never applied, and also about half of people reported that the hospital never told them of about charity care. We don't need to get into the nitty gritty if the hospital actually told them about charity care, because I think in most instances, the hospital probably complied with the law to give notice. But the broader point that we took from this is that notice is ineffective. Patients they're not reading it, they don't understand it one way or the other. The message just isn't cutting through. Next slide, please. So is charity care easy? The data suggests no. About a quarter of patients describe the process as hard or very hard. And we found that there was a 10% increase in approval rates if the patient got help from a third-party patient advocacy or from someone who filled that role at the hospital itself. So approval rates go up quite a bit when they're getting help from an expert, essentially, which indicates that this is not a super easy DIY process for them. Next slide, please. And then, is charity care administered fairly? 14% of applicants responded that they just never heard a response to their application from the hospital. Transparently, I thought the number was going to be higher. Our patient advocates constantly have to resubmit applications for hospitals, and application wait times are often measured in months and not days or weeks. And probably conversely, even though that number didn't really surprise me, the one that did shock me, and I think all of us, was that we found a 62% lower probability of being approved for Black patients than all other racial groups. We have no idea why there's such an equity problem in the administration of charity care, why it's failing that specific group of people. But the numbers were pretty consistent and pretty stark. Next slide, please. So just to leave everybody with like some of our thoughts on, we see that this process is not, patients don't know about charity care. It's not easy to get through, and these programs are not administered fairly. We think a big part of the problem is that patients who are almost always in some sort of medical event, or are sick, have this burden to learn about these programs and then to apply and get through that application process, which is not as straightforward as most hospitals think that it is, even internally. When you actually try to experience it boots on the ground, we are, this is not, the presentation where we get into all of our policy ideas and internal ideas for how hospitals can improve these programs, but we do have a whole host of those ideas that all boil down to restructuring, philosophically thinking about these programs from being a system where the patient has the burden to learn about and apply for these programs to a system where the hospital just gets everyone screened. It's just part of their discharge process. It's just built into their billing process. We have we also think there's a lot of room for partnership with industry and with advocates to get better tools available and hosted by the government to enable hospitals to do this. We're not into just some sort of difficult mandate that's impossible for them to jump through the hoops, but we do think that there's a lot of room for improvement as the data suggests. Next slide, please. So I think this is the last substantive slide. We're talking about costs, we're talking about affordability. There is a question of, okay, $14 billion, that is bad for patients to take on as debt, but how much would getting charity care to 100% allotment, getting that 29% of people who get it up to 100%, what would that do to hospital revenue? The data we have suggests it wouldn't really have a significant impact on hospital revenue. It would probably just dramatically reduce hospital bad debt. The national survey that we did found that only 7% of patients who were denied charity care ended up paying their bill. And we have more data in Oregon than we do in Washington or a lot of other states. So that's why we used Oregon OHA data. But from the time that we pulled this, 2021 and 2022, only 1.6% of revenue was reported as patient self-pay revenue. The rest came from some other third-party payer. So this is a small chunk of overall hospital revenue, and it's a small chunk within that small chunk that we're talking about. But that pot of money, that pool of money, because of the laws of scale, is the #1 cause of bankruptcy in the United States. So we think that the payoff could be well worth, what might be like a marginal decrease in overall hospital revenue. Next slide, please. I just always end with a happy slide of happy patients. So I am done. Thank you.
Hi, I'm Julia Kellison. I'm a staff attorney at Northwest Justice Project. And next slide, please. Northwest Justice Project is the state's, Washington's largest publicly funded legal aid program. We provide free civil legal assistance to eligible low-income people out of about 20 offices statewide and through our statewide intake line, the Clear Line. And I'll talk about those resources at the end of this. I coordinate a weekly remote debt clinic. We went remote in the pandemic. And next slide, please. I've been working on charity care related issues for over 20 years as a legal aid attorney. As Eli mentioned, this is such a big driver of bankruptcy and all kinds of credit and debt issues I'll get to. In terms of how we get our medical debt clients here in King County, they come to us through the debt clinic I coordinate, cross referrals from other organizations, and outside of King County, they tend to come to us through our statewide intake line, the Clear Line, where folks are referred from lots of different other partner agencies or through online intake. So in terms of the income of the folks that we serve, our clients have household incomes of mostly 0 to 200% of the federal poverty level. So for a household of one, that's a gross monthly income of $2,510. Household of four, that's a max gross monthly income of $5,200. One of the reasons we started our debt clinic in 2011 is we knew there were persistent debt collection abuses going on, and medical debt has been our client's most persistent debt problem since I've been practicing law for decades. And we started it started as a courthouse-based clinic. Again, we went remote at the beginning of COVID, but medical debt has always been this enormous driver of debt issues for our low-income clients. So if folks come to us with medical debt that's charity care eligible, from hospital debt, there's a lot we can do to assist. Washington's charity care laws are very good. On the whole, we can stop all collection activity using our charity care laws and WACs. Most of our clients have already been sued by the time they come to us. So we can suspend the lawsuit, help the client apply for charity care, and once awarded, that lawsuit's going to get dismissed. That's if they get to us. I bird dog every charity care application and case I get because I want to know the kind of barriers that my clients are facing, and there are many. Next slide, please. If the debt isn't charity care eligible and the client's not covered by Medicaid, that presents really big problems for my low-income clients. Many clients are low-wage workers who earn too much to qualify for Medicaid. They can be underinsured with not great private insurance that has really high cost sharing. When the client's billed for non-hospital physician time, radiology, labs, ambulance bills, those are just some examples. All of those aren't covered by charity care. Our clients are not able to afford to pay these bills, and they can be really, really high. There's no requirement that these non-charity care covered entities offer any financial assistance at all for low-income patients. And if they do, sometimes it's really time limited. So by the time the client finds out about it, that window to apply for financial assistance is long past. In Washington, the statute of limitations on medical debt is generally 6 years. Debt collectors can hold on to that debt right up to the end of that time period before they sue. So the client may not get any notice that the bill is in collections. And if the healthcare provider fails to send the bill to the client's insurance by the time the client finds out about the bill when they're sued, the time period to submit the bill to the insurer has passed. Next slide, please. In terms of credit problems, medical debt of over $500 can remain on a person's credit report for 7 years, ensuring that our low-income clients are going to get worse credit or loan terms on a car loan. Rental housing can be much harder to get when that credit is impaired with medical debt or any other type of debt. If the client sued for non-charity care eligible medical debt for which there's no affirmative defense like charity care, a judgment's going to get entered at 9% interest. And that judgment can last up to 20 years collecting interest at 9%. Once a judgment is entered, a judgment creditor can then choose to collect on its judgment by a wage garnishment. That's one option to the client's employer. And up to 20% of a client's net disposable wages can be garnished every paycheck, with a nice little $300 debt collection attorney's fees being added to that debt every 60 days pursuant to our garnishment laws. So each time that wage garnishment is renewed every 60 days, $300 of attorney's fees get added, which, as you can imagine, extends the life and the pain that this garnishment inflicts on people. Next slide, please. Another method that judgment creditors use is to collect on judgments is through a bank garnishment. So our low-wage worker clients can have all but $1,000 of their bank account wiped out if that medical debt judgment creditor chooses to collect through their bank account. You don't get notice of a bank garnishment, which makes this whole process particularly destabilizing. Clients' access to the money in the account can be completely cut off for weeks, which of course jeopardizes the ability to pay rent and other necessities, which can lead to housing instability and homelessness, and the inability to meet basic needs. So adding to this debt nightmare is the fact that if a debt collector is collecting on public debt, including debt from public hospitals, and we see this routinely, a provision in Washington's Collection Agency Act at RCW 1916-500 allows the debt collector to charge the debtor a fee of up to 50% of the principal of the bill for no additional work being done, just because they have this juicy provision in the Collection Agency Act allowing this additional fee, which can, again, mean thousands more dollars added for the privilege of being debt collected on to the bill. So as of 2019, bench warrants for medical debt can no longer be requested by collection attorneys for a judgment debtor's failure to show up at the supplemental proceedings calendar, which is a post-judgment hearing. Folks in the Yakima area were routinely jailed for medical debt, and largely for debt they didn't know because they were low income enough to be our clients. So that process, we got that process stopped as part of our consumer coalition, raising those issues. And, you know, as we all know, all of this debt and nightmare for clients and involuntary debt collection causes enormous stress on my clients, which of course leads to worse health outcomes, cause families to go bankrupt, and worse yet, avoid medical care in the future, as Eli's slides and discussion pointed out as well. Next slide. So here's how, folks, please do send people our way. We love working on medical debt and charity care cases, and we can provide a lot of relief to our clients, again, if it's charity care eligible. And these are the ways to reach us.
Thank you so much, Eli and Julia, for both of your insightful presentations, and thanks for keeping it tight. I know we ran into your time. So, you know, we've discussed medical debt a few times before, but hearing that $14 billion in charity care opportunities are missed each year really puts the scale of the problem in perspective. With the cost board's goal of addressing healthcare affordability, it's clear that medical debt cannot be overlooked. It's one of the leading reasons why people delay or avoid necessary care. So I'd like to turn this over now to Gary Cohen from Health Management Associates to lead us through a medical debt policy reflections and discussion so we can start to wrap up this topic of medical debt. So please open to tab 6, and Gary, please take it away.
Thank you, Bianca. I saw a hand raised. Eric, do you have a comment before I get started?
Well, I just had a comment. I appreciate the presentations. On Eli's presentation, there was a lot of national and Oregon information provided. And some of the information provided was 21, 22, right in the middle of the pandemic. But I think things in Washington has very different charity laws for hospitals than most states. And I would caution about using national data or even Oregon data for Washington State, and even data from 2022 versus now. Hospitals have there's been change in requirements and change in practices. So I just want to point that out. I think in Washington State, I know that every time a hospital sends a bill, on that bill is information about charity. And I don't know if that happens in other states, but I know it is hard to inform patients, but I think Washington State hospitals are trying. That's all I'll say for now. Thank you.
Thanks. And I think the issue of what data is available in Washington as opposed to elsewhere is going to come up in the conversation. So why don't I start, Emily, and we'll come back to you. So Audrey, if you could skip down 5 slides to the one that says today's focus, medical debt. Yeah, so the purpose of this part of the discussion is to hear from you all on what areas you think to address this issue the cost board would be best suited to and should spend its time and effort in looking at and making possible recommendations. So we've divided up different approaches to addressing the issue of medical debt into these 3. The first one is kind of what we've been talking about a bunch today, preventing people from getting into debt by, among other things, making it easier for them to obtain financial assistance that they're entitled to under the law. The second is to do things relating to collection practices. And the third is to make sure that we have the right sort of data about what's happening with respect to medical debt in order to inform possible policy options. So if you could skip ahead, Audrey, to not this one, but the next one. This is another way of looking at the same question that came from some policy suggestions from the Attorney General's office. The first one, again, measuring medical debt more robustly than we're doing now. The second one being financial assistance. And then the last one, enforcing charity care and community benefits, or as been happening around the country in some places, buying up existing medical debt. Okay, so if we can skip ahead. This is just more detail. We're not going to go into the specific policies right today, I don't think, although we're happy to hear from people on that. But really, okay, if you can go to the next one. Among the different aspects of approaching this issue, we'd really like to hear from you all as to where you think the board should focus its efforts. And with that, I will open it up for discussion and comment.
And Gary, just since many people don't have access to maybe to the board materials, do you want to go back to the slide from which the policy choices that we're focusing on?
Yes, that's a great idea. So why don't we skip back up to the one that said
one more before.
Is this the one you meant, or the one before?
Yeah, that's the one I was thinking.
Okay. Yeah. Okay.
So members, this is your chance to chime in. Do we want to go back to Emily to see if her comment is appropriate now? I think you had a hand up earlier.
Sure, I'm happy to kick us off, and I know that folks will have a lot to say on this topic. So first of all, thank you very much to the incredible presentations that were shared earlier from Julia and Eli. I have heard both of you speak before, and every time I hear both of you speak, it makes me a little bit sadder about the state of our healthcare system. And I think Eli really illustrated the financial magnitude of the harm, and Julia talked about the ways that medical debt follows people throughout their lives for care that they needed to receive. I also appreciated Eric's comment about needing to look at Washington data. I will note that in many years of working on charity care in Washington state, including recent years, that charity care problems arise all the time in Washington state. It is a topic that we hear from our consumer discussions and discussions in communities every single time we go out to talk to communities as problems in charity care and medical debt. So I take this topic really seriously, and it is a very, very important problem in Washington. With that said, I think you asked us to talk about the cost board's role in this area. And here, I think that the discussions that we've had over the last couple of months have been very important in understanding the depths of the problems and around medical debt, charity care, enforcement, and the ways that our cost pressures harm patients. But the cost board's role, as Gary mentioned, is unique in Washington landscape, and that really is to think about what the underlying drivers are and be taking action upstream and looking at policy solutions upstream so that we don't have so many patients getting into medical debt in the first place. So I would like to encourage the cost board to continue to measure and monitor and discuss these issues around medical debt. The cost board has an underinsurance survey coming up, and I would suggest that this is a set of data points that should be prominent in that survey, because it is important to have Washington data, as Eric noted, and it's going to be important to understand the cost board's effectiveness over time. But I think that we really need to focus the bulk of our policy discussion as cost board stakeholders on how we prevent people from getting into these issues in the first place, focused on high and variable pricing as the foremost policy concern for us as cost board stakeholders. So I'll maybe start us there. I think one last piece I'll just say is that we are in a shifting landscape and a dynamic landscape at a federal level now. I do think it will be important for Washington policymakers writ large to pay attention to those changing pieces at a policy level. So, for example, the Consumer Financial Protection Bureau had put forward medical debt proposed rulemaking that undoubtedly will not occur now at a federal level. And so I think it behooves us as Washington state stakeholders to look at the gaps, to look at where there will be new gaps that arise, and consider state-specific policy solutions in the coming period. But I don't necessarily know that it's the cost board's role to propose those policy solutions. So that's my my long-winded answer, and happy to hear other people's thoughts.
Thank you, Emily. I see Patrick's hand. Want to chime in?
Yes, thank you. I agree very strongly with Emily's comments. I think that medical debt certainly is a large issue that needs to be addressed. But I think in this context, it ought to be looked to more as a metric, a symptom of the problem. And the cost board ought really to be focusing more strongly, more directly on those cost drivers rather than the symptoms. Let's try to get to the cause of the disease. And I tend to think that given the fairly large number of folks and organizations that deal with this issue directly have firsthand experience, many years of that firsthand experience, along with the analysis and recommendations that were developed through the Attorney General's office model policy that's in front of us. I find myself personally feeling ill-equipped to outdo the experts when it comes to making recommendations. So perhaps if others sort of share a similar concern, that might be further cause for us to take this in, to look at it as an important metric, but really defer to those whose expertise and research have led them to already make recommendations before sort of ham-fistedly proposing any of our own.
Great. So I'm seeing some emphasis on prevention of accumulation of medical debt, and I do want to note that Sulan also noted that that they also second the comments that Emily made. I see Justin's hand.
Yeah, sorry, I can't join by video. I'm off and on with power, so I'm using my cell phone internet network. So I would also second or third the suggestions from Emily. I definitely can see the value in understanding the issues with medical debt, but at the same time, from a provider perspective, and I think for a lot of our members over, as far as like nurses go, looking at really what are those drivers, and I think it's a lot more impactful for us to really focus on policy changes that lower the burden of potential debt, rather than dealing with the debt once it's already incurred, and really focusing on that concept and that part of this.
Thank you, Justin. And I see that Bob also emphasized that Emily's points. So just noting that. Eric's hand I see is up. Go ahead, Eric.
I just wanted to say, in the goal of preventing the accumulation of medical debt, one thing we could add to that list is insurance benefit design. Because I think we've gone to $5,000 deductibles, even some $10,000 deductibles. And I think if we ignore how insurance is designed, I think we might miss an opportunity to help prevent some of this accumulation of debt. Because I think that's a lot where a lot of very high amounts come from.
Good points. All right. I see Emily's hand back up again. Oh, you're on mute though, Emily.
Thank you. I appreciate that thought about insurance design, and here's where we get into a tricky issue, which is that for plans in the individual and small group market, at least, that insurance design is driven by the actuarial value calculator, and that is driven by cost trend at a national level, and there's no way out of that because it's federal rule and law. So I think while I appreciate that concern, and you're certainly right, Eric, that we are seeing more and more people with insurance, employer-sponsored insurance, and what we might think of as kind of typical commercial insurance facing medical debt, and running into problems with charity care. The problem is cyclical because it is related to the underlying cost trend.
Thank you, Emily. I'm going to have Michelle have the last comment, and I think we have to wrap up for this hour. So Michelle, please go ahead.
Yeah, I a lot of what I'll say will just echo, I think, what Emily has said. I here on the panel, I'm representing the perspective of employers who sponsor health insurance, and certainly agree that deductibles have been going up. There's significant percentage of employers who offer high deductible health plans, which has lower premiums that in terms of the employee share. And so employees enroll in that often, perhaps because it's what they can afford. But yeah, the underlying driver behind cost shifting to employees, particularly for smaller employers, is the underlying cost. That is the driver.
Thank you, Michelle. Gary, finish us out.
So I just wanted to wrap it up. This is really helpful. I think this will be really helpful for the board. So I want to thank you all for your input. I just wanted to ask in the last second if there's anyone on the committee who disagrees. I'm hearing a lot of consensus, but I just wanted to ask if there's anyone who feels differently from what the consensus seems to be.
Dorothy's hand.
I don't disagree, but I think we can do more than one thing at a time. And so when I hear the description of people that are in just agony with medical debt, it seems like there may be just some focus on for the cost board and making sure that we're enforcing the charity care and community benefits pieces that we already have in place here. Because if that's not happening, that it is just producing pain for people that we don't want. So while we're going upstream, it seems like we could also address some of that more in a more strong way.
And I do want to just note, I see a question from Louise Kaplan that says, what is the amount that the Transparency Board includes in its calculation when determining the cost of care? If the hospital is charging full rate, but should be discounting it, what is the amount used? I don't think we are currently accounting for debt, but I could be wrong about that. Doesn't sound familiar as part of our conversations thus far, because I think we're, as I think Eli pointed out, we don't have very good data, I think, on this topic. So, and I see Emily's hand. Last comment. Nope, on mute. Let me unmute.
Thank you. I want to say that I really appreciate and agree with Dorothy's comment that we can walk and chew gum at the same time. I think we have had rounds of discussion on this topic, and we started this topic by articulating a long list of policy measures that could prevent immediate harm for medical debt. And I think Julia and Eli talked about all the ways that people in Washington and elsewhere are relying on those policies. And so I want to be careful to note that my thought was just that the cost board in particular has a very unique role to play that no other parts of the landscape can play in looking at underlying drivers. And so it's really important for us to both support measures around medical debt and surface those issues and track it on a state level, and where there are failings, and also do the primary work that the legislature asks the cost board to do.
Great, thank you, Emily. And I do want to also note that Patrick also put a comment in here about some efforts that are ongoing in the state to focus on state-based financial premium assistance. So with that, we are really kind of already pushing into our next meeting, which is with a joint session here with the advisory committees of stakeholders and data issues committees. But this brings us to the end of our meeting today. The recording and summary of this meeting will be posted shortly on HCA's website. So thank you again, Eli and Julia, for presenting today, and Gary for facilitating this conversation. And so thank you to the committee members for attending today. So we'll just